So thank you, everyone here. And I'm actually finding this very fascinating in the discussions, but even the discussions afterwards, because I really hadn't looked at our engagement in care through a health literacy lens, and I think it's really, I'm finding it quite helpful. So this is actually going to present how we're using cell phones and mobile phones for patient engagement in care without a lot of reference to health literacy literature, so that's where you can help with the discussion. So the mobile health seemed like something of the future, not so very long ago. I don't know if you recognize the person in the far right, but really mobile phones, because of their increasing ubiquity of use around the world, which actually includes most parts of the world today, has really lent to the possibilities of how do we use that as a communication tool, rapid wireless communication tool for health purposes. And I thought it's appropriate to use Wikipedia as a definition source, as it being an online source, but education, helplines, diagnostic treatment support, healthcare workers, disease epidemic outbreak tracking, remote monitoring, really almost every part of the health system you can think of, there's the potential for interventions. I work in HIV, but as many of you know, HIV is primarily a chronic disease now. In fact, most people live a near normal life expectancy who take treatment, so it's really about managing the chronic disease, and in fact, many people with HIV end up managing other chronic diseases as they move along through life. So this cascade of care has really been used widely in HIV now, which is prevention, testing and diagnosis, access and linkage to care, access to the treatments, and then adherence, and then retention. And really, if you were to put that arrow in perspective, everything would put here, and then adherence and retention would be a very, very long bar. And there's a lot of hype around it, but in the HIV world, and I was doing my fellowship to learn to do open a vaccine lab, which I never did because of this, but in Kenya. So I went to move to Kenya, did some immunology, but while we were there, you can see the dark bars is the HIV epidemic, largely affecting resource-limited settings, and sub-Saharan Africa most dramatically affected. But the treatment response, although delayed, has been quite dramatic more recently, and then the scale up of medication use is now actually over 9 million people accessing antiretroviral care globally. So there's been a rapid scale up of treatment, but this treatment requires lifelong engagement in care. And then the dark bars is actually, again, the resource-limited settings. And then if we look on the right, and these are actually getting a bit out of date already, this overlapping huge growth of cell phone technology and its use around the world actually overlaps mostly. Its largest growth is also in resource-limited settings. So we have potentially this tool in the settings where the problem is and the solution is, and then how can we use the tool for that. So can they actually improve HIV care was our question when we started scaling up. And we actually got the multidisciplinary team around, which included everyone from the clinic doctors, nurses, counselors, driver, lab techs, and patients around the table saying, well, how can we use you're using your phones for everything else in your life. How can we use your business, your personal life? How can we use them for improving your health management? And they actually came up with, again, HIV, there's stigma and privacy at a very high level to think about. Also a lot of logistics about costs, when people want to have access. And what they actually came up with is a very, very simple thing, which has been hard for us to maintain, and that was they wanted access to care, so it wasn't reminders. They could set their watch alarm. It wasn't the alarm function so much as the communication, so communication with health providers. And they also didn't want it to say HIV because someone else could see their phone, or even clinic for that matter, and they may not have disclosed their status. So really all it, doesn't have the words, didn't show through. But really all it is was a system where we sent out a weekly text message that says Mambo, or how are you, to patients once a week, and then they respond Sawa, which is fine, or Shida, which is a problem. And if there's a problem, then the nurse usually calls them back and sorts it out. And now I'm thinking in terms of health literacy, what are we actually teaching them? And the point I think that we took is what was their value? And their value wasn't for us to teach them something on their phone. It was to give them access to someone who they trusted, who would have the types of knowledge and being able to triage that information on their behalf. We also, because it was very simple, and didn't say HIV, we allowed shared phone access So for instance, there's an 82-year-old woman who was recently in a remote community, Maasai community, didn't speak English, newly diagnosed with HIV though and starting treatment, and her grandson texted back every week on her behalf whether she's fine or not, and if she wasn't fine then the nurse would speak to her on the phone. So it was really keeping that level of access very low, but at the same time almost near instantaneous in people that are sometimes making less than $2 a day. So we studied this in a randomized clinical trial at 3 different clinic settings in Kenya, 2 urban and 1 rural, and we randomized patients to either getting a text message that checks in on them or standard care alone. And in fact, one of the concerns with this model of asking everyone how you are is you're going to get inundated with problems, and how on earth you're going to manage all of these calls. But in fact, what we found is that in the first 3 months after starting therapy, only 6% each week identified a problem. And we know that that's the time when people have the most questions and also the most prone to side effects, and they're still maybe sicker, but after that down to 2%. And when we looked closer at those were generally health-related questions that came up over that time. So on average 3%, so a nurse following 1,000 patients only had 30 patients each week to call back, and those were the patients who were the most in need. So the clinicians actually found it very efficient in terms of use of their time of being able to reach out to the patients who were self-identifying as most in need. Thanks Mosins here actually who did the statistical analysis for us. But if we looked at subgroups on the, and so we measured patient adherence at 1 year, and we measured did they achieve a viral suppression to undetectable level at 1 year. So in fact, in all of the subgroups, when we're breaking down, there seemed to be a benefit. So we didn't really see just one group, whether they were urban, rural, older, younger, sicker, less sick. They seem to all report at least a trend towards improved adherence in the SMS group on the left of the line, or the control group. And so that was a behavioral outcome. So did we influence their health behavior? This simple text messaging and checking in them seem to have reported, at least by self-report, that they were more likely to have taken their medication. So that's a positive health behavior. But we don't just care about positive health behaviors unless they improve health. And as a biologic marker, at least, achieving a suppressed viral load, we know is a good marker, objective marker of a better health outcome. So improved adherence by 24% and achieving viral suppression by 19%. And this is a very busy slide that just essentially looks at the types of questions that they had were quite variable, mostly related to health, sometimes related to logistical issues, but I'll come to that with some of our work. And this phenomenon of using cell phones to manage health was actually it listed in one of the top 10 positive stories of Africa for 2011, along with the fact of mobile money and the fact that we can show that we can improve health outcomes in health. But how does it work, asking this question? And this is just one little caption that might, to me, of the qualitative work that we're doing now to understand how it worked post hoc and how it works going forward as we try to adapt to new environments. Often just knowing that we have supports that are there and knowing that we have the backup or the ability to make contact relieves so much anxiety, and that's a direct quote from a patient. This is a remote patient actually in British Columbia now. So there were there's actually emerging randomized trials in this. So there was a second trial that looked at text messaging that actually pushed out information that was meant to be motivational. So it said, your medications are important, you're doing well. But it didn't have a response mechanism. And what they found is doing that daily actually had no effect on adherence. Doing it weekly, especially if they looked at short messages, which rather than a long message, a motivational message, was actually effective, but daily was not effective. So telling people over and over too frequently the same thing, that they're doing well, seemed to have no additional benefit in adherence. And it also maybe says to us that it's not reminders, but it's engagement in care and it's access to support and triage that may lead to improved health behavior rather than reminders. And I think we have to be careful about telling people information that they already know and it becomes very challenging to figure out then, if you do so, what is the right message that you can actually tell everyone that they'll still value as being important to them? If you tell me, take my medications, I'm going to be healthy once, you probably don't need to tell me that 30 times in the next month. But somebody else may value some of that information. So one size fits all becomes challenging, and that's why we tend to have stuck with asking, how are you? Because how are you actually kind of is one size fits all, because you can have a million different answers, and it's still appropriate. Reminders or support. So there's a randomized trial that looked at adherence counseling. So this is actually now more in the health literacy of education. So they actually had adherence counseling. It's not really written literature and tested, but that was very effective at proving adherence and viral load outcomes. But an alarm device given to them, timed when to take the medication, actually had no benefit at all. Not that reminders don't work. I think it's that people already use reminders, and if you add reminders, new reminders, you may have already saturated that. That's one possibility as well. So there's been Cochrane reviews that suggesting that text messaging now at weekly intervals is efficacious in enhancing adherence to ART, and it's starting, and it's making its way into adherence guidelines and retention guidelines for, at least for HIV care. And adherence is cost effective. In fact, we used the results from our study to plug into some models that were done by others, but basically when you improve adherence, you reduce the risk that people are going to have health problems. You may reduce also the risk, in this case, of developing drug resistance. That can be costly. So it becomes, behavior change for adherence and retention is highly cost effective. And I think you can plug any intervention into that model and you would find the same thing. Lots of emerging data. I don't have time to go through it all, but there are other aspects. One that I found very interesting, also published in The Lancet, was that sending treatment guideline reminders to practitioners who were treating people for malaria actually showed that they demonstrated in an objective way that they were more likely to provide the correct treatment according to the guidelines by providing that information in text format to health providers. It's more the BC context of the distribution. It looks very sparse, but if you look at cell phone coverage, it still covers most of the population throughout the province, and including the black dots are where the health facilities are. So we've been adapting the work in British Columbia, and this is Karen, one of the nurses at the Oak Tree Family HIV Clinic. And we have an automated platform now to deliver, so patients get registered at the clinic and basically get the text messages, how are you, and respond. So can they do it? I'll just say it's sort of a modern thing. The automobile wasn't invented for health, but it's certainly effective in health in this model. And I think we can say that maybe the same for cell phones, maybe not invented for that purpose, but certainly something we can use. And we're doing a number of projects to do with retention and care in HIV and TB and other aspects. And chronic disease, I think the model is very similar. As I mentioned, HIV and TB are essentially chronic diseases. So just my take-home messages as I'm running out of time. I think for me, keeping it simple, and I think that comes back to the message being appropriate for every level of complexity makes somebody who can't use it and do it. Respecting privacy and low cost, of course, but following the evidence, because what we think may work needs to be tested. And that was more of a description of what we've done, but I would welcome thoughts on health literacy when we have questions.
Yeah. Any quick questions, Andrew? Yeah?
Sure, thanks. So what if you, well, in fact, you had about a third of the people who didn't respond to the text message at all. Do you know what's going on with that?
Yeah, so we did an evaluation because it was recorded when there were messages came, what the content was, and when they weren't reached. So everyone who didn't respond was called after 48 hours. So one of the ways to improve that in terms of efficiency now is that they get a second text reminder, and then the next week. What we found, though, is that the people who didn't respond usually did respond again at a subsequent week, and then they were able to ask what happened, and most of the time it was logistical things such as they were traveling or their battery had died. in fact, that it was our anxiety from the healthcare side that something terrible has happened to them generally didn't pan out, and usually they were logistical issues, and people were transiently out of care. Yeah.
And so then, has anybody taken this technology and said, okay, we're going to shift from adherence to prevention, and maybe tied it with community level engagement?
Sure.
My bias, I said magnet theater, which has got a long history there, on especially addressing stigma to try to prevent. Is there any evidence that tying this technology with something in the community would make a difference?
So there is. I mean, there was actually a text messaging trial that showed that encouraged people to use sunscreen. That showed that they did use sunscreen more. So there's a prevention in terms of prevention messaging and behavior change, which I think is more. What I'm finding with our model is we're using it in treatment for latent TB infection and now for pre-exposure prophylaxis for HIV in San Francisco, where patients are healthy and well, and in fact the value of having access to the clinician is lower, and I think we're finding that the sicker patients are, the more they value access. So prevention, I think, is a powerful area we need to look at, and that might be the side where pushing out the right messages that people value is more important.
Great.
Yeah.
Thanks very much, Cameron. Or, sorry, for Richard. I was thinking of my next introduction.